Thank you, guys. Very happy to be here visiting from Atrium in Charlotte, where I work, and I'm going to talk to you about, okay, perfect. All right. So I'm going to be talking to you about MOG antibody disease today. I'm going to start off with giving a little bit of an overview of the disease, and then we'll get into some of the management options as well. And as you'll notice, there's some overlap in my talk with Dr. Dumovic's. So just to start off, wanted to highlight the fact that we do see a lot of overlap in these various autoimmune neurologic diseases. And as Irina had mentioned, I would venture to guess that probably many of you in the audience today had previously carried one of these other labels, because many patients are often misdiagnosed as either MS or NMO disease, as this is a pretty new discovery that this is a distinct process with MOG disease. So MOG antibody disease is a rare antibody-mediated autoimmune disease of the central nervous system, just as Dr. Dumovic had described with NMO. I actually find MOG to be one of the most challenging diseases to treat, because it's kind of a either-or situation. So this disease can be monophasic. You can have a one-time event, or it can be relapsing, and it's actually about a 50-50 split. So when somebody comes in and they're presenting with that first initial attack, it can be challenging to try to distinguish those. Just a little bit more about the prevalence of the disease and epidemiology. So this occurs in about 1 in 50,000, so much less common than its cousin in the MS world. And it also, different from NMO and MS, has an equal preponderance between males and females, and it doesn't seem to have any specific preponderance for various ethnicities. Similar to the other autoimmune diseases that we're talking about today, it typically occurs in young adults, but distinguishing MOG antibody disease, a fair number of these, about half, will actually occur in children. So I know this is a busy slide, but I'll walk you through it in several steps here. So this is the diagnostic criteria, and I think one thing that's important to highlight is the fact that these were published in 2023. So this is a very new disease, even though we've been talking about some of the characteristics and animal studies of these disease going back into the 80s. It's really only been in the last 20 years that we even discovered the MOG antibody, and I would say really the last 10 years that that's been widely available for us to commercially test for it. So that's why I said many of these patients were, maybe mislabeled as MS many years ago, but not that long ago we were looping these in with the NMO spectrum disease. But now we're discovering that it is distinct, though there's some overlap. And I'm going to point out here a couple of the key criteria. So for diagnosis, if a person has one of the core clinical events, which is optic neuritis, transverse myelitis, an ADEM type event, we'll talk about that, or a brain or brainstem event, and they are positive for the antibodies, if they have a clear positive antibody test, then that's all you need to make the diagnosis. That's the end. If the antibody testing is less clear, then you need some additional steps. So that's that bottom part there of these other supporting factors. So, and you'll also notice here that the NMO antibody, there's no category here that says completely negative. So you really can't definitively make the diagnosis without a positive MOG antibody either found in the serum or the CSF. When we're talking about here the clear positive versus low positive titers, we're talking about the titer. So sometimes you'll get an antibody and you'll get a number attached to it. And typically we say that if somebody's less than 1 to 100, that's considered a little bit more questionable because you can see some false positives in that range, and that's where you want to see another supporting feature. Another thing that I see as a bit of a mistake that I see in practice sometimes is the fact that this MOG antibody is very sensitive and it's very specific to MOG antibody disease as long as we're testing it in the right group. So if someone is just broadly testing for antibodies, you're going to find something oftentimes. So it's much less sensitive in that way. So it's not recommended that we should just be testing everybody. You really want to test in people that have that kind of, typical presentation. So what are those extra characteristics, those supporting characteristics that help us to distinguish this a bit from NMO disease or even from MS? So one of the supporting features is with optic neuritis. So we look for certain clues that are more suggestive of MOG antibody disease. So with MOG antibody disease, patients often have bilateral optic neuritis. That can happen with NMO as well. So again, you'll see nuances there. And then this picture is showing us, so the bilateral involvement. It also typically involves more than half of the optic nerve as well, so it's a long segment. Again, that's similar to NMO. But one of the things that is unique in this MRI, I'll just point out, I was trying to show you, so that line right there, if I can stay on it, that's our optic nerve coming back from the eye. And you can see that whiteness is not supposed to be there, and it's traversing most of the optic nerve. Something that's a bit unique compared to the optic neuritis that we see with NMO or with MS is that these patients, when they get enhancement, it often happens on the sheath on the outside of the nerve too. So that's a little bit of a clue. When we're looking at patients that are presenting with myelitis, so there's other characteristics that we'll look for there that might give us a clue that's more suggestive of MOGAD versus NMO. So similar to NMO, these patients often will get long, extensive lesions within the spinal cord as well. A little bit different is they tend to not be complete cross-section of the cord, but it's more of a portion of it. And one thing that is unique is this, what we refer to as the H sign there. I think you got to squint to kind of make out the H, but it's in the middle of our cord is where the gray matter is, and MOG has a preponderance to affect that particular portion. And then so you see the whiteness there in the cord kind of looks like an H if you stretch your imagination a little bit there. So that's a little bit unique and a clue that we can look for. This is not present in everybody, but it's something that we can look for. And then another unique feature, which I don't have a picture of this on the MRI, but a lot of patients will have this affect the tail part of their spinal cord, the conus, which is a bit different. And then in patients that are presenting with more the brain or brain stem component, then again, looking for some unique facets here. So these patients, a lot of times will have more of an ADEM type presentation, so they have multiple lesions around the brain. A lot of times that comes in the form of encephalopathy where they're tired and have a number of different symptoms correlating to these various areas. So it's kind of, this is not the greatest example, I wouldn't say, but the lesions tend to be these big fluffy lesions, whereas in MS they tend to be very discrete borders there. So that's somewhat unique to MOG. They oftentimes will affect the brainstem, and different from what we see with NMO, where it affects what we call the area prostrema, a very specific area that leads to intractable nausea, vomiting, hiccups. With MOG, when it affects the brainstem, it's oftentimes either in the pons, medulla, or specifically there in the connection between the brainstem and the cerebellum, and again in a way that has, as you can tell here, this white area is like a large kind of fluffy type lesion there. Another unique presentation is people can present with encephalitis where they're getting inflammation around the covering of the brain. That's what this is showing. Those squiggly lines are inflammation that we see there in the covering of the brain. And those presentations can oftentimes come on with seizures as well. So that's unique to this disease. So just a few things that help us in terms of clues with diagnosis. And then this slide also goes into helping to distinguish between a few more. And again, I know that's really small, but I'll put it in here for reference when they share the slides. But distinguishing between MOG in the first column here, NMO, and then I highlighted some of the key things so you can actually read it. So, in contrast to the other diseases, we talked about some of the epidemiology factors already. With optic neuritis, again, we chatted about the bilateral nature. These patients, similar to NMO, often have very severe edema in the optic nerves. When this is happening, that distinguishes from MS. But one thing that is different is even though they'll have very severe presentations, oftentimes with maybe complete vision loss when they come in with optic neuritis, they actually usually have pretty good recovery, which is different than what we see with NMO, so that's positive. Similarly, when they present with transverse myelitis with spinal cord involvement, same thing. It can be very severe at the onset when they're coming in with the relapse, but many times patients have pretty good recovery, especially with their motor function, their strength, weakness. These patients can oftentimes have some residual bladder or sphincter issues, but they tend to have good recovery of their strength. And as I mentioned before, similar to NMO with those long lesions. We talked about the brain presentations. And then the other two facets that I wanted to mention with this disease, which is a bit different, is similar to what Dr. Dumovic was saying around NMO, that these patients really don't have progression in between their attacks. A little bit different from NMO, though, as we said, they often get good recovery. So they have a relapse. They usually recover pretty well, so not left with as much residual deficits. And then you really don't see progression in between the relapses. So that's positive, because if we can prevent the relapses, then we can really prevent the impact of the disease. And then the other thing that is unique, you know, when I was in training with MS at least, it was always real to us that lesions don't go away. You know, once you have the lesion, it doesn't go away. That's not 100% true, but it usually is true with MS. But with MOG, very different. MOG, the lesions do go away. So that's also something that I look for. These patients will have, you know, lesions when they come in the acute setting with their relapse, and then I re-image them some months later, and they oftentimes do resolve, at least get better. So just to give you a little bit of the proposed pathophysiology of this disease, and this will be relevant as we talk about some of the treatment options here as well. So this busy diagram is trying to show you what's happening here. So you have the B cells. Some of this Dr. Dumovic has kind of went over, but I'll tell you the differences. So you have a B cell that's specific for the MOG protein. We think oftentimes maybe some kind of trigger sparks the differentiation, although we don't know what that trigger is. But those B cells will differentiate into a plasma cell, which is going to produce those MOG antibodies. It needs some T helper cells to be able to make that differentiation. And then when it does, it's releasing these MOG-specific antibodies here. Those antibodies and those inflammatory cells can at times then cross over the blood-brain barrier and get into our central nervous system. And when they're in the central nervous system, they attack the myelin, the MOG protein that's present on the outer part of the myelin and will cause inflammation there. And one of the things in terms of pathology that distinguishes this disease and how we recognize that it is a very distinct pathology compared to NMO is that this disease impacts the myelin, typically sparing the axons. That's probably why we see good recovery of function. And it attacks more of the oligodendrocytes, which is responsible for making myelin, whereas NMO attacks a different cell, the astrocytes. When this happens, you'll also see a number of different cytokines, different chemicals that are released that really spark the immune system and spark inflammation, and that is the target of some of the therapies that we're looking at. So I'm going to switch gears here and talk a little bit about treatments of MOGAD, and that could be a very short presentation because there are no FDA-approved treatments for MOGAD. Furthermore, there are no completed clinical trials for treatments of MOGAD, and so what we're left with is experience and small studies, which is not ideal, but I'll walk through those and what we do know. So before I go to the maintenance therapies, I just want to present a little bit. I always talk to patients. My philosophy when I'm thinking about treating patients is really three arms. We have the acute treatment. So if we have a relapse, I need to treat that acutely, try to shut down the inflammation. I need to put you on some kind of maintenance therapy to prevent that from happening again. And then that's not all that we should be doing. We also need to be thinking about symptomatic therapies, because if individuals are left with residual symptoms, then we can address those as well, because really the first two sets, the maintenance therapy, it's not repairing the immune system, it's not repairing the nervous system, it's really just there to prevent that inflammation from happening again. So I'm going to focus on the first two parts, and then we'll have a symptomatic talk down the road. And I'm not going to belabor this because it's exactly the same as what we talked about with NMO. So for acute management, really for all of our immune-mediated diseases, there's really just a few mainstays of therapies. Usually our first line is to do high-dose steroids. Plasmapheresis is kind of a second line for people who don't respond. And then IVIG, and I would say maybe a little bit of uniqueness that there's some indication that MOG in particular responds to IVIG, whereas we don't use that quite as much for MS or NMO. So we'll get into more of the maintenance therapies, which is unique. So this is actually a paper that was published just on expert survey. So this was really just about what are you using. So they asked 52 neurologists, people that were experts in the field of neuroimmunology. And I will note this is from a few years ago, so hopefully this would be changed a bit now, but they asked him what's your go-to treatment for MOG in first line, second line. So first I'll say there wasn't even consensus on whether or not they were treating them or not. So I think we still have a lot to learn. So about 60% of those that were surveyed said that they were treating patients after that first event. I would hope that that would change a bit now. Most people, because as I said, it's about a 50-50 on whether or not somebody's going to have a one event or they're going to go on to have a second event, and that's even for those that are testing antibody positive. That's why I find this disease challenging. Most people have agreed now that we probably don't need to treat it at that first event. There's some nuances to that, and if somebody has very severe residual symptoms, you might make a different determination because it can be a little bit of a gamble. But again, even in surveying, there wasn't really great consensus on when to pull the trigger with treatment. And then as you can see, it was sort of all over the place with the different therapies. Really kind of standing out, I'd say the mycophenolate, azathioprine, rituximab were kind of the most commonly used medicines first and second line. You even had some that when they asked them about, well, what do you use third line, they just said, well, I don't even know. I don't even know what I'm going to do in that case. So we've got some stuff to learn. And again, to be fair to those surveyed, again, we don't have clinical trials for the disease yet, so it can be difficult. So the next few slides here I put together is really a few different review papers that are presenting a compilation of studies that were done and the different treatments that were tried. So as I said, there are no completed clinical trials. I'm going to talk to you about some of the stuff that's going on right now, but none that have been completed and published yet. So really what we're left with is a lot of retrospective reviews, kind of real world data. And as you can see, they're pretty small. So this first column here gives you the number of patients that were enrolled in each of those. And then also when you're doing this retrospectively, it's really just kind of real world experience. So we don't get a lot of details on, did they have other issues going on? Was this a second line therapy, a third line therapy? So it just makes the data muddy, to be honest. So pay attention to this column here, and I just blew up the numbers so you could see it better. And I just want to make note that they're presenting this as the percentage of patients that did have a relapse. So even though I mentioned that mycophenolate, imurand, azathioprine, or rituximab, those are still the commonly used medicines, you can see that a large number of patients were still having relapses on these. Again, with these not great studies that we have to work with. So, again, all of these are in the range of, with mycophenolate, it's almost 3/4 of patients are having a relapse during that time, over half of the azathioprine patients and rituximab patients. I'm going to present some other numbers here that look a little bit different too. IVIG, again, was one that stood out. That looks the best, right? IVIG, only 20% had a relapse. That being said, I would say there was only, I think it was 10 patients in that study. So it's a little bit hard to know what to do with that information quite yet. This is another paper on rituximab. This one looks a little bit better, though. So rituximab, this is 120 patients, and I would say rituximab is probably still the most commonly used, although that's kind of changing now. But so we do tend to have more of these papers published with it. But this particular review, again, it's still a hindsight sort of presentation, but 120 patients, about half of them, when you just looked at it in the bucket number, about half of them remain relapse-free. But if you started to break it down, you could see that when it was used as a first-line treatment, well, it was 63% reduction in their relapse rate. If we looked at it as after beyond first line, then it was much worse than that. And then they also looked at here the relapse-free patients, and you can see again 79% if it was used first line, but that was only following patients for a year, and that's true of a lot of these studies too, about a year, year and a half, which is just probably not long enough for us to get a good view. So similarly, just different publication, but again, a compilation of various retrospective studies that have been done, same kind of drugs that we're talking about. And then I show in the column here on what's the percentage of patients that were relapse-free. You can see, again, IVIG kind of stands out as one of the best there. Again, a little bit smaller than some of these other studies, though. And then tocilizumab, I'm going to come back to because there is a clinical trial that's ongoing with this medication right now, and that one really stood out as having a higher percentage of relapse-free patients. So this is oftentimes now starting to be used, again, all of this off-label, but as at least a second-line therapy for patients. Again, pretty small. We're just talking about 10 patients published. So I'm going to share with you some of the current, hopefully emerging therapies out there. These are current clinical trials. And one thing I will say, so when I did a search on clinicaltrials.gov, there were only a handful of studies out there for MOG antibody disease. So still a lot of work to be done. But I'll highlight a few of these that are current, and these are all actively and currently enrolling. So rozanolixizumab, that's hard to say, Restigo is the brand name for it. This is a medicine that is out there because it's currently approved for myasthenic patients, but it is being studied right now in a phase 3 study for MOGAD disease. So this is a medicine that works by binding to the FC receptor, which is involved in recycling of antibodies. So it helps reduce the levels of those antibodies. So if you think about in MOGAD, reducing those MOG IgG antibodies in the bloodstream. It's a subcutaneous infusion that's given. And right now, as I mentioned, this is an ongoing openly enrolling study. It's expected to be completed in 2027. So we still have a couple years to see what happens with that. Tocilizumab, which I've already mentioned, as this is something that is out there. It's currently approved for lupus and rheumatoid. So this is something that we're starting to see people use for MOG as well. But thankfully, there's a study going on to look at it so we get a better picture of how well this drug works and its safety in a larger population. This study is just open in China, but is currently open and enrolling as a phase 2/3 study. Tocilizumab is one of those monoclonal antibodies which works to reduce the IL-6, so one of those pro-inflammatory cytokines that I mentioned, and help to decrease inflammation. Satralizumab, or Enspryng, some of you might be more familiar with that name because that one is already approved and is being used for neuromyelitis optica. So there is a study going on. It's at multiple sites across the U.S. and internationally, actively recruiting to look at this medicine for MOG patients as well. So, and Elena's already mentioned the mechanism here. So this is another IL-6 medication. And then CAR T therapy, I found one study in China specifically with this treatment. Dr. Dumovic had mentioned this as one of the potential treatments that's being investigated for NMO as well. And in fact, this particular study that's going on is not specific for MOG. It's actually enrolling any refractory autoimmune CNS disease, so MS, NMO, MOGAD, and myasthenics are open in the study, and specifically those that have broken through with other treatments. So the CAR T therapies, so this is a genetically modified T cell, which is modified to target and destroy specific target cells that And it can be used for various things. It's used primarily in the cancer world right now. So we can target it to attack, say, B cells, and they're actually harvested, modified to express that CAR antigen, and we can target specific antigens with it that way. So I think can be a promising therapy. This is kind of early study, so this one probably not expected to be finished until 2029. So we still have a few years to go. I will, pause with that for a moment to say this really does underline the importance of clinical trials and research, especially when you're dealing with rare diseases, because otherwise you just can't make much out of that real world experience, to be honest. And so I think these are very important, and just like we've seen in the NMO world, I think as we have some of this come out, we're going to learn a lot more about MOGAD as well. So just a few key takeaways, and I'll sum up here. So as I mentioned, MOG antibody-associated disease is really a newly recognized autoimmune disease. So I still think we have a lot to learn about this particular condition. While there's a lot of overlap with MS and NMO, there are distinct features. And as we mentioned, some of those features, we can look at the clinical presentation, the MRI features, the spinal tap results that may help us to distinguish between some of these other conditions, but none of it is completely definitive. I do have a number of patients in my clinic that they really have a very similar presentation, but they don't have those MOG antibodies, they don't have the NMO antibodies, and so we recognize that there's probably other antibodies that we haven't discovered yet. Just like we discovered MOG some years ago, I think we'll probably see others in the future that help us to better label them. And then we talked about the importance of clinical trials. And then I just wanted to end with resources for future too. So these are several nonprofit organizations that you guys are probably already familiar with, many of them, that really focus on these rare neuroimmunologic diseases, because we know that MS tends to get a lot of attention because it's the more common disease. So I think it's great to have events like this today. And I know that we are at time, so I think we'll probably pause questions. I put my email up there as well, but we'll pause, and happy to answer questions over the break, though, or during the question session. Thank you.
Thank you so much, Dr. Graves.